Hello orthopods. In the previous two videos, we have discussed about developmental dysplasia of hip, the introduction, the incidence, and then we have gone through the associated conditions and why there is very difficulty in relocation of the hip, and then we have talked about the presentation and the basic diagnostic techniques that we use for the diagnosis of DDH. So now today we are going to see about the management of the DDH. Okay, so the management will be very crisp and I'm going to make it very simple, okay, with very minimal headings. Okay, if you want to know regarding in depth about the ultrasound and the diagnostic techniques and also regarding the surgical osteotomies, etc., I'm going to make one more video in which I'm going to go very detailed regarding the osteotomies. Okay, so without any delay, let's just dive right through the management. Okay, so when we come to the management varies according to the age. So I've divided the age groups into 5 groups. First group, newborn, that is 0 to 6 months. Next, infant, 6 to 18 months, that is 1.5 years. Next, toddler, that is 1.5 years to 3 years. Next, child, 3 to 8 years. Adolescent and adults, that is more than 8 years. Okay, so first is less than 6 months. So in the less than 6 months, as I've already told you, the clinical examinations play very important role in the diagnosis. The supportive test what we can do here is ultrasonography. Okay, that is why, because if you do an ultrasonography, it will tell us whether to start the brace or not. Okay, in order to take that decision, we'll start doing an ultrasound. Okay, so here the main treatment will be application of Pavlik harness. Okay, it is called as flexion abduction brace. Okay, flexion abduction orthosis. It is worn 23 to 24 hours per day. The success rate is 85 to 95%. So that is a very high success rate. Okay, what we are going to do in this Pavlik harness is we maintain a position of the hip and knee so that the hip stays in a completely reduced position. Okay, so that is the condition we maintain by using a Pavlik harness. So as the child grows and the diagnosis goes undetected, the success rate of this Pavlik harness reducing the hip will be very low because there will also be something called as muscle contractures. Okay, so during that time it will be very difficult to apply this Pavlik harness. Okay, so one of the most dreaded and dangerous complication with this Pavlik harness is osteonecrosis of the femoral head. Okay, so how do we use this Pavlik harness? That I'll tell in a separate video. What are the straps that are used and how is it applied, etc., and all those things. Okay, the harness is very difficult to use in the children who are crawling and who have fixed soft tissue contractures and fixed hip dislocation, that is teratogenic dislocations. Okay, in these teratogenic conditions it is very difficult to apply this Pavlik harness. Okay, so next, the reduction. How do we confirm the reduction? As I've already told you, ultrasonography. Okay, the ultrasound will help us to diagnose whether it is reduced or not. How do we know whether it is reduced or not? The femoral neck will be facing towards the triradiate cartilage. Okay, that is how we know whether the hip is reduced or not. So persistent dislocation after application of harness. This is one of the complication. Okay, not a dreaded complication but most commonly seen complication. So there are different types of dislocations. One is superior dislocation, one is inferior dislocation, one is lateral dislocation, one is posterior dislocation. The posterior is most difficult type of dislocation to reduce and also to manage. The next is lateral dislocation. In the lateral dislocation you can just observe, but if the neck is facing towards the triradiate cartilage, you can just neglect the lateral dislocation. Next, inferior dislocation. If there is an inferior dislocation, try to decrease the flexion. Okay. Next, superior dislocation. Superior dislocation, you have to give more abduction. Okay, additional hip flexion. Sorry, you have to give more hip flexion. Okay. Okay. So next thing we are going to talk about is when do we have to remove the Pavlik harness. Okay, so if the dislocation or subluxation persists for 3 to 6 weeks, okay, without any development, then it is better to discontinue the harness. Okay, the patients will be examined every 1 or 2 weeks, and in order to look for the quadriceps function. So the one of the other complication with the Pavlik harness is femoral nerve palsy. Okay, so femoral nerve palsy can be identified by the parents itself while applying the Pavlik harness or while removing the Pavlik harness. So while removing the Pavlik harness, you will just leave the baby like that and observe whether the baby is able to flex and extend the knees perfectly or against the gravity. Okay, if the baby is not doing so, I recommend you take the baby immediately to the doctor and get checked. Okay, and the other way that we discontinue this Pavlik harness is 6 weeks after clinical stability. Okay, so these are the two things. Now we have completed newborn, that is 0 to 6 months. So this is how the Pavlik harness looks. So you can see the cute baby and the Pavlik harness, how it is applied. Okay, so in case of irreducible dislocations, bilateral hip dislocations and femoral null palsies, it is better to discontinue the Pavlik harness. Okay, so and also one more thing is, if the acetabular angle of more than 36 degrees is present on x-rays and initial coverage of the femoral head is less than 20%, so all these conditions and the application of Pavlik harness has been delayed, so late application of Pavlik harness, so all these conditions we cannot rely on the Pavlik harness. Okay, we have to look for other management techniques. So the further management technique will be open or closed reduction of the femoral head. Okay, followed by hip spica. So next is the infants, 6 months to 18 months. Here the babies will be more symptomatic, so the Pavlik harness might not give the success rate as seen with the less than 6 months year old babies. So the x-rays will also show some modifications. There will be delayed ossification of the femoral head and lateral and proximal displacement of the femoral head. There will be shallow acetabular display, shallow dysplastic acetabulum. All these things can be seen. So in order to reduce the dislocation, what we do is initially we give something called as pre-op traction, but some studies suggest that the pre-op traction has no effect on reducing the dislocation. Okay, so next thing is we have adductor tenotomy. So we have already discussed that the adductor muscles get contracted and they become very tight. So we can give a small subcutaneous incision and we can do tenotomies. Okay, next if these two fail, then we go for open or closed reduction. After doing open or closed reduction, we are gonna confirm the reduction by CT or MRI. Okay, and we'll confirm the stability. If it is stable, then we apply hip spica. Okay, the hip spica will be applied at 95 degrees of hip flexion, 40 to 45 degrees of abduction. This is a safe zone. Okay, in this safe zone the hip spica will be put. Next, the spica will be immobilized for 3 to 4 months. The cast can be changed under anesthesia. The open reduction techniques will be anterior or medial approach. Okay, next we have child more than 2 years. In this type we can also note shortening. Okay, so here we have to go for open reduction and femoral shortening with or without pelvic osteotomies. Okay, next, more than 8 years, pelvic osteotomies give better outputs. So we have 4 classes of osteotomies. Class 1, the osteotomies that redirect entire acetabulum. We have Salters, double innominate, triple innominate. Next, class 2, incomplete cuts were made within the innominate bones, Pemberton and Dega osteotomy. Type 3, Chiari medial displacement osteotomy and shelf procedures, that is shelf arthroplasties. Type 4, hybrid osteotomies. Okay, hybrid osteotomies combine the osteotomy techniques along with the shelf procedures. Okay, thank you. We'll wind up the topic with this. In the next video, I'm going to make the full-on description regarding the osteotomies and also the USG classification of the developmental dysplasia of hip. Okay, using a graph method. Thank you. Kindly like, share and subscribe. Thank you. Hello orthopods. In the previous 2 videos, we have discussed about developmental